Welcome to Ask Syd, the official podcast for Sydenham Clinic, a clinic where luxury meets medicine. We are on a quest for longevity. And I am so thrilled to be your host on this show. My name is Anchal Bhatia. I am the founder and CEO of Sydenham Clinic and the author of Your Doctor Is Not God and How to Be the CEO of Your Health. I look forward to taking this journey with all of you and having amazing thought leaders, guests, and members of our Sydenham team answering questions that you put forward. And I urge you, and I hope you will, ask Syd more questions on longevity, wellness, living to your highest potential. We are all trying to be the best versions of ourselves, and our physical, emotional, and mental health is foundational for us to achieve health and success in other realms of our life. So welcome to Ask Syd. Welcome back to Ask Syd, and as you can see, I'm joined by our medical director, Dr. Terry Rice, who has been here before, and today we are going to talk about space medicine and how Sydenham is actually contributing and has been an academic partner to some of the physicians here at NASA. So you know we're in Houston, Texas, home to the NASA Space Institute as well as the prestigious Rice University. So very recently, the Baker Institute at Rice University organized a symposium on international space medicine. And Dr. Rice was invited as a speaker there. Dr. Rice, tell us, why were you invited to a space medicine conference?
Yes, it was so cool. So of course I was surprised because I don't have any special training in space medicine. But I do have a couple of space medicine physicians to the astronauts who are my patients.
Yes.
And they invited me to speak because some of the things that we do at Sydenham Clinic are very cutting edge, and they would like to influence what is being done for the astronauts to see if they're fit for space, and also to see how we can improve their health through their time working in space and afterwards as they mature and retire and get older.
And your topic was very interesting, and your talk was it was really enlightening, even for people who've been in medicine, who've been in space medicine for 20, 30 years. There were astronauts there. So that's what I wanted to discuss about today. You had taken a few examples, you've taken case studies of patients and how we're doing primary care so differently here.
Yes, yes.
And I think that those anecdotes or those case studies is something that we all can relate to. So what did you talk about at that conference?
Right. So I talked about a couple of families and how our utilization of genomics as part of our primary care had led us to provide better care to family members. And one of the case studies that I gave was about a family who had come in to see me. Originally, the son was my patient. And the son had considerable atherosclerotic disease, but this is related to a gene that he carries, which is called ApoE4. And for our audience, I don't know if they're aware of this or not, but there is a gene called ApoE4, which essentially controls your lipid metabolism in your central nervous system. And that gene is very common. It's carried by 26% of the population. And it is a considerable risk for vascular disease, cardiovascular disease, heart disease, okay?
Right.
But also triples your risk on average of Alzheimer's disease or developing dementia. Okay?
That's a double whammy.
Yes, it's unfortunate, but of course there are lots of things that we can do, and it's not an uncommon finding at all. So anyway, this gentleman came to see me, and we determined that one of the reasons that he had premature heart disease was that he was a carrier of this gene. So as you know, Anchal, when we see our patients, we do a pretty extensive genomic analysis.
Yes.
We look at about 800 different SNPs, they call them, but it's essentially genetic variants. And this is just one of the ones in the cognition panel. But it is also a big risk factor for heart disease. And so we determined that the main reason that he had this premature heart disease was that he was a carrier of this gene. So then he sent his father to see me. So his father came in to see me for fatigue, and we did a full evaluation of him and his heart, and we determined that he had atrial fibrillation, which is irregular heartbeats.
And he did not know this before he came to Sydenham?
He knew. Now, the first patient did not know, of course, that he had this genetic
because he was
variant.
so young. How old is the son?
He was in his young 50s, his early 50s. The father, though, only had irregular heartbeats, and we think that's what was causing this atrial fibrillation, this arrhythmia, was causing his fatigue, but he didn't have any cardiovascular disease, okay? So no vascular disease. And when we did his genomics, he didn't have the ApoE4 gene. So the father would always come with the young man's, my other patient's wife. Like, they were such a cute couple, just really like little lovebirds. They were always talking to each other, did everything together, and he would always tell me, oh, she's so healthy, she's got perfect metabolism, she can eat anything she wants, you know, she's an athlete, and he was always talking about what fabulous health that his wife was in. But the son was carrying this gene, and the father was not. So it had to come from somewhere,
from
right?
The mom.
From the mom, who was not my patient, but who was visiting with the father, right? And so after we learned this about the father, I finally turned to the mom and said, you know, you probably have this gene, or you have to have this gene. Your son had to get it somewhere, so you should be evaluated for this. So she became a patient at Sydenham, and then lo and behold, of course, when we worked her up, we found that even though asymptomatic, she had pretty significant vascular disease.
Wow. And she's slim, she's not obese, she's fit, she does yoga.
Slim, very fit, yes. And so we found that she did carry the ApoE4 gene, of course, because we really kind of knew that by deduction, but also found that she had a significant amount of heart disease. Now, you know, women are different than men when it comes to heart disease. They often don't have symptoms. If they do, they may be different from men's. They're not as straightforward. But it is the #1 killer of women in America today, is heart disease. So when we did her genetic analysis, we found not only did she have 1 copy of ApoE4, she has 2.
Wow.
And that is a very important finding, because that means that her risk of developing cognitive decline or dementia is over 50%. And she has an older sister that already has Alzheimer's disease.
That explains it.
Yes. So, you know, it was a good finding because we were able to intervene. She wasn't getting any treatment for her elevated cholesterol, and we were able to intervene and start to take steps to give her things to help with her cognition long term, supplements, lifestyle choices, and also intervene on her vascular disease.
Because very often, like I've heard you say, it's diagnosed 20 years too late, especially dementia and cognitive disorders. It's 20 years too late. And with her heart disease, maybe her first episode would have been fatal, or it could have been very scary, right?
Exactly. Now, I know in men, the most common symptom of a heart attack is death. In women, I couldn't really speak to that exactly, but of course it is very important in women as well, because it is the #1 killer in women.
That's interesting. You say that a lot of times women go undiagnosed and women have different symptoms. So maybe you could just, you know, segue a little bit into what we as women should try and look out for, because especially healthy women who, like us, who work out, we're fit, we look skinny on the outside. What are some of the symptoms that we should look out for, or some of the things we should do?
Right. Well, I mean, I think that really with women, their chest pain may be vague, more vague. It may not be squeezing sensation. It may be located in the back. or they might not have any chest pain. I think the most important thing with women is that they should be screened as men should. You know, you hear about men doing stress tests all the time, but you don't hear about women. And at Sydenham Clinic, we really don't do stress tests anymore.
Yes.
You know, we're much more aggressive. So we start with a CT calcium score, and that tells us if we have underlying heart disease or heart disease developing. And then we know that that LDL cholesterol needs to be treated, and not just said, oh, you're a woman, it'll be okay. So I think it's more about screening and early prevention.
Right.
And you know, that brings another case to mind about another family, another very interesting situation where the mother was my patient originally. She was the first patient, okay? And she had some genetic differences. She had a gene called Lp(a). So again, this is a lipoprotein. It has to do with cholesterol metabolism, but it's probably the most important risk factor for heart disease, okay? Now, from what we could tell, she didn't have any heart disease, but she also had what's called factor V Leiden, okay?
Mm-hmm.
And factor V Leiden means that she's at increased for blood clots. So these women should never be on oral estrogen. Okay, so they should never be on the birth control pill because it increases the risk of blood clots. They should not be on Premarin, you know, for hormone replacement therapy. And she asked me to see her daughter. And when I saw her daughter, she had both the Lp(a), which is the risk factor for heart disease, which, by the way, one of the ways it causes heart disease is by causing tiny blood clots in the lining of the blood vessels. And she had the factor V Leiden, which increased her for risk of blood clots. Mm-hmm. But she had a really elevated cholesterol also. So that was different. And then I asked her about that, and she said, well, my dad has high cholesterol. So she not only got these independent risk factors for heart disease and blood clots, but then she got this high cholesterol from her father. So I told her, I said, you know, you can't take the pill. You have to come off the pill. So we got on a different form of birth control. And then a year or so later, her father came in, and he became my patient. Mm-hmm. And so when I met him, I knew, even though he was already on cholesterol medication, that his cholesterol had been really high. Not when he saw me, because he was on the most aggressive cholesterol medication possible. He was on several things for his cholesterol. Right. But I knew it had been very, very high, okay, because I'd seen his daughter.
Yes. And
hers was very high, like 200 when she was in her early 20s, okay? Her LDL cholesterol, young. Not her total cholesterol, right? So back to her, I went ahead and treated her. Like a lot of physicians may not want to treat someone that young with a statin or other medication, but I treated her immediately because she also had this Lp(a) and this factor V. So she had these clotting risks, other heart disease risks. So even in her 20s, I started her on medication for her elevated cholesterol. And then when I saw the father, I knew where his cholesterol came from, and before I'd ever met him, it had been very high. And so I was talking to him about his heart, and he said, oh, you know, my heart's fine. I had a stress test just a few months ago. And I said, oh, you know, I think we should look a little deeper. So we did a CT calcium score on him. So that looks for calcium deposition in your coronary arteries, and it was elevated, significantly elevated. So then we went ahead and did what's called a Clearly test.
An AI-enabled.
An AI-enabled CT angio, where it actually shows you pictures of your arteries, how much plaque is in them, how much of it is calcified, how much of it is just cholesterol, soft plaque, and how much of it is this very soft plaque, which can rupture and cause a heart attack.
And that's the dangerous plaque, right?
And that's the dangerous plaque. And even though he had this normal stress test, when we did that, we found that he had significant coronary disease and was in danger of having a myocardial infarction sometime in the future. Nobody knows when, but enough so that we did send him in to a cardiologist, and he did get stents placed. So it's become
fascinating,
real interesting how the genetics have helped us, work back and forth between family members. And also in this family, the mother, who I said had this clotting issue, this factor V Leiden, her sister had just had a blood clot in her leg. And then of course she asked me, well, what about my son? So we also investigated him to make sure that he was okay.
So it is fascinating how your genomic-based primary care practice is discovering things that your cardiologist should be discovering, or things that your gynecologist or your endocrinologist who's working on your hormone therapy should be looking at. So I really feel like this is the right way to practice primary care, really, where you can have a full view thanks to their genomics and an overall like a blueprint, sort of.
Well, I think it really adds a lot of value. And as I've been doing this longer and longer, I'm starting to really see the value that it adds. A couple of other little case studies, real quick things. We have another family where the mother and father both are carriers of hemochromatosis, really common, over 20% of the population. And this means that they overabsorb iron, okay? That is more important in men, particularly if you have two copies, because men don't menstruate, so they tend to hold on to the iron. And then it is deposited in their pancreas, and their liver, and in their testicles, and in other places in the body. But it is one of the most common causes of cirrhosis, is this over deposition of iron. So
it goes and deposits in the liver?
It's just stored in the liver, and then it causes scarring and eventually cirrhosis if it's not caught. So when I found that the mom was a carrier and the dad was a carrier, both of them were fine, but I said to the mother, do you have a son? Because he could have two copies.
Absolutely.
One from each parent. And so they sent him in when he was home over the holidays, and his iron studies were super high. So he most likely, we don't have his genomics back, but he most likely has two copies and is at risk for hemochromatosis. And this is easy. We're telling him, don't eat iron-fortified cereals, don't take a lot of vitamin C. A lot of people think, oh, just all the vitamin C, I should take a bath in it, Well, actually, that increases iron absorption. It's not always a great idea to take too much of it. Don't eat out of an iron skillet. And just donate blood. That's all he needs to do, just to keep his iron stores down, and then do a good deed at the same time. Just donate some blood.
And a lot of us think like one size fits all. Vitamin C is good for everybody. Eating out of an iron skillet is good for everybody. And these are preventive steps you can take so early on.
Yeah.
But most primary care doctors or most specialists don't know what to do with your genomics report. They're like, okay, so you have two copies, or you've come with this fat 150-page report. What am I supposed to do with it? But I think all these cases that you've shared today shows that there is so much you can do with that information.
Yeah. I think sometimes people have the idea like, why do I want to know my genetics? What can I do about it anyway? Well, this is what you can do about it, right? You can do a lot with it.
And it's simple stuff.
Yeah, if you're just armed with some knowledge.
And then because you're monitoring them, you're also preventing and making sure if there's early onset, you can reverse it.
Yeah.
It's great. Well, the astronauts need to learn from you. And I hope that they are able to incorporate our style of practice for their astronauts, especially with space travel becoming private now, with private aviation.
Right.
They don't have those rules about you can't do the genomics, or what does the insurance pay, or the government pays. So I think all the stories you've shared today, the case studies you've shared today are very enlightening. And all of us can relate to something. Like, I know we have fatty liver disease in India, and again, I never thought of it. They could have the gene, and it's not fat. It could be iron. So please keep coming back and sharing more case studies and Ask Syd. And to all our listeners there, please keep sending your questions so that we can bring some more fun content and informative content, because in 2024, there's so much new stuff that we're embracing here at Sydenham Clinic, and we keep bringing all that cool stuff to you. So until next time, remember, health is by choice, not by chance. See you back soon.